Hello, everyone. Welcome to the October coaching call. If you all could just chat in your name, your pronouns, and where you work, that would be great. And we'll just start in a few moments, just waiting for a few people to join at the lunch hour. I wanted to let everyone know today that we will be able to offer nursing, continuing education credits, and then a certificate of completion for social workers as well. Okay, well, we will get started. So I am happy to introduce Dr. Kaylin, Klie and Matt Holtman. They will be presenting today on the child welfare process for postpartum people who screen positive for substance use disorder, specifically in the labor and delivery unit. So I wanted to share with you their objectives before I switch over to their slide deck. Okay. Let me switch to the other slide deck. Zoom does not make it easy to switch between slide decks. I just had it up.
Elena, I did update one slide at like the 11th hour. So if you want me to share my slide deck, I can. Like
whichever you want. I have it on the Google document, so it should be updated.
That's the updated one. Yep.
Okay, sweet. Okay, I'm sharing my screen. Can you all see that? Sweet. Well, Dr. Klie and Matt Holtman, take it away.
Sounds good. Thank you, everybody, for being here. We can go to the next slide. So I'm thinking of this like chronologically a little bit, right? That you know, we're probably going to spend the bulk of our time talking about what happens when a person has given birth, they're in the hospital, it's during that birth hospitalization. And then we're trying to think about, does this person or family require, do we have concern to warrant a suspicion or referral to CPS kind of in that postpartum space? But what I'd like to talk about a little bit is kind of what this looks like prenatally. And so this is the Colorado Revised Statute. And what this says is, I think most of you are very familiar with this language, right? That we then mandated reports, right? Any who has a reasonable cause or known or suspects that a child has been subjected to abuse or neglect shall act immediately and report to the county department, local law enforcement, or through the 1-800 CO for Kids reporting hotline. And so I think that's probably the background language that most of us have in our minds is like, when in doubt, make a report and have CPS kind of work it out on the back end. Next slide. But then this is what I think of as like the plot twist, right? So this is the update to the Children's Code. And what this did is it took out, so this is actually a screenshot of the actual legislation, what this bill looks like that got signed into Colorado law. And you can see there is truly a strike through where it says any case in which a child strike through tests positive at birth, right? And what the language changed to is that any child, a case in which a child has been born affected by, right? I don't know if any two words have ever kind of like caused so much hullabaloo in the healthcare system, but affected by alcohol or substance exposure. And so now really our work is to determine what is affected by mean, right? But it's alleviated us from having to mandated report, reflexive reporting based on toxicology alone, right? Sometimes I'll talk with my patients. I take care of mostly people who are, themselves the the potential parent or the birthing parent. And, we talk about urine doesn't give us any context, right? Toxicology says positive or negative, but it doesn't tell me anything about how that substance entered that urine. It doesn't tell me anything about the circumstances, the intent, and potentially what's happened since, right? So especially when we're talking about infant umbilical cord testing, just to keep in mind that that really is going to show as positive or negative from about the second half of pregnancy. And so that doesn't tell us, potentially a person who had opioid or let's say fentanyl use up to week 28, that doesn't tell that person stopped using and got treatment, now has been sober, right? It just says positive fentanyl. And so I think really understanding the limitations of the timeline, that, toxicology doesn't give us a timeline necessarily as a standalone measure. Okay.
And I just want to say one thing on the wording. It took us 10 years to get to this wording, understanding it wasn't perfect, right? But in Colorado, the original, before SB 2028 came to be passed, we had work groups set up in the legislation for 10 years and were unable to, with our community partners and medical partners, child welfare, and on the table, we were unable to come up with anything. So just to know, we understand we probably didn't get to a perfect solution, but we got to one where everybody in the room gave a little bit to get here. So it took a lot.
Yes. I don't mean to say affected by caused hullabaloo without recognizing the incredible hard work that it got to. And this is groundbreaking, because really I think what has for so long prevented people with substance use from revealing their substance use struggle, from coming in for prenatal care, from potentially even wanting to have their baby inside a hospital, has been this previous language, right? That any positive toxicology, it was interpreted, and or even other scheduled medications, right, could potentially be reportable. So you can see how that would have a double whammy of wanting people to not only avoid detection of their substance use by the healthcare system, but potentially people even having feeling deterred from accessing medications that could potentially be reported. Okay, next slide. So for me, the big takeaway as a patient-facing clinician, it's de-emphasizing that focus on toxicology. It removes the reference to federal schedule substances, right? So federal schedule is the DEA schedule of, Schedule 1, no recognized medical, legitimate medical use, high risk for misuse. Federally, that includes THC, but you can see, right? And so you can see how it was really important to remove the reference to the federal schedule, because the federal schedule increasingly does not reflect actual state laws or legality of certain substances, or reflect actual research that's being done on some of these, I would say including THC, and increasingly you'll see more research being done around LSD, MDMA, psilocybin, right? There's more research going on these substances that have been for a long time scheduled and has prevented research, but also has fallen into that reflexive, in the old language, reflexive reporting. It elevates the impact to the child as the main consideration and advances at least a 2-generation, I would sometimes say a multi-generational approach, right? So this could include grandparents, this could include kind of extended family as well, approach to keep parents and their children together during treatment. Right. So not saying we want you guys to be together when you get sober and when you've been in recovery for X amount of time. If and when it's possible for you guys to be together while you're working on treatment, that is the goal. Next slide, please. What this legislation also introduces, and what the revision HAPTA law, which Matt can talk about in minute detail if questions come up, but the revision of that language really promoted the instead of reflexive reporting, that actually what we're responsible for is a plan of safe care. And so this is just pulled straight from child welfare. It's a plan, childwelfare.gov. A plan designed to ensure the safety and well-being of the infant with the prenatal substance exposure following his or her release from the care of a healthcare provider. So for us and our purposes, being discharged from the hospital after birth is the most common scenario. By addressing the health and substance use treatment needs of the infant and affected family or caregiver, right? So it's not only a plan about the infant, although they have a starring role. It's a plan about kind of what does this family need as far as resources, referrals, and support. And so I've listed several of those things here. I think the other thing that sometimes becomes interesting and is a point of discussion is who's responsible, right? After a family leaves the hospital, who's responsible for monitoring this plan of safe care? And really, there's no law that says who that has to be. It really is about who is involved in the family and has been identified as components of the plan of safe care. So that could include, care providers for the infant. That could include care providers for the parents, could include some home visiting services. It could include other, professionals, including Child Protective Services, but not necessarily. There's no law that says that the plan of safe care must be monitored by Child Protective Services. Okay, next slide, please. The ideal time to start a plan of safe care, in my mind, is when you determine that this person or family is likely to or potentially likely to have risk factors for reportability. And so for me, that includes substance use and pregnancy. And it really helps pull in some of these supports earlier so we can have a discussion about what this looks like. I think some of the most interesting conversations I have with patients, especially patients that I take care of who have ongoing use of substances throughout pregnancy, right? I think we have kind of this magical wish that pregnancy would be the magical motivating factor, that every person who's pregnant will be ready and desire sobriety. And in fact, those time periods in people's lives just sometimes don't overlap, right? The readiness for treatment and recovery may not overlap with, thankfully, the temporary time period of a pregnancy. And so talking very openly and honestly, especially with those folks about, what is likely to happen? What does this process look like in the hospital? Who would you be likely to talk to? And where does that information go? Right? So demystification of this process. I think most people ask me, will you take my baby away? Right? Like, is it the doctor? Am I going to take your baby? But have kind of some fear that anybody in the hospital could take their baby, right? And not really understanding the process in which removal of custody happens. And then it's not something that the nurse in the hospital or the social worker or the doctor in the hospital would do. And I think it really maximizes for me when I'm bringing up this plan of safe care with families before birth. It maximizes the opportunity to engage in those conversations separate in time and space from the incredibly stressful event of having just had a baby. So if I think about when I would most like to talk to somebody about a high stakes, high emotion conversation, it would not have been anywhere near having just given birth. That is an incredibly physically and emotionally demanding. And for our folks with substance use, even just being inside the hospital, especially if we haven't really anticipated what that person might need as far as medications for withdrawal, sleep, right? We may not have totally conceptualized kind of how they're feeling from a substance perspective. It's a really challenging time for folks to show up as their best selves, right? I think all of us included, but particularly people who are in this extremely vulnerable position of having had a baby and a history of substance use. And so I like being able to have these conversations in hopefully a lower stress environment, in a paced fashion, so that we can talk about one piece of it, today, because you're hopefully not going to have your baby for another few months, and then we can talk about another piece at another visit. And I think it hopefully helps reduce the stress on that person and their family of having these really potentially emotional conversations. And with that, I think I get to hand over to Matt.
You do. So good afternoon, folks. Again, Matt Holtman. I am the CAPTA and Federal Funding Administrator for the Division of Child Welfare. I still get about 35-ish folks on. I can talk forever about anything, quite frankly, depending who you ask, but especially on making referrals and making reports for an hour or two. So, and that's not even the substance exposed newborn part of it. So if you want to just use chat real quick and throw a couple of like questions that you all have and want to make sure that they're answered before I wrap up, I can make sure I hit on those things. Me talking and you listening for 35 minutes and not getting what you want out of it's not going to be helpful for anybody. So feel free to use chat and I'll try and look at those and as I go through slides. Also, I am 100% open to interruptions throughout the presentation. So if there's questions, comments, concerns, complaints, congratulations, I take those too throughout the presentation. Raise a hand and somebody can stop me from talking because I can't see quite everybody, but please utilize that.
Yeah, and feel free to put it in the chat and I'm happy to interrupt Matt as well.
Awesome. Cool. Slide, please. So again, most folks do a great job, by the way, for making referrals when you make the referral, having all the information, right? You guys are medical professionals. You guys have made these types of referrals in general in the past, or somebody in your agency has, or somebody in your organization has. There tends to be some historical knowledge, so we kind of know what needs to be, in the referrals. This is the bare bones, right? Demographics, what's going on, family strengths and supports. And then for a substance exposed newborn referral, we would love to have a plan of safe care along with that. Doesn't matter what's on it, right? It doesn't need to be something that's completed, right? Kaylin said something great. Like if you have one that was done prenatally and maybe then updated again, right? Because life changes and things happen, we'll take both, or we'll take the most updated one. The plan of safe care in and of itself may be enough information to prevent child welfare from getting involved. It may be, because of all the work around support and things like that that have happened beforehand to support mom and baby through this process. Also, as a father of a 9-year-old and watching my wife go through labor and birth and all of this, I can't imagine having any serious conversation, quite frankly, like the 24 hours before birth and the 48 after. Whatever my amazing medical staff told me and my wife at that time, I don't even know you exist. It was just a straight blur. So having something as serious as you might not go home with your baby, right? Like I can't imagine trying to handle that conversation at that time. So there's that. Next slide, please. So there's a lot of concern sometimes along like what happens. Like we call the hotline or we call the county, right? So we have those good partnerships and those good relationships, and then crickets, right? Like did child welfare even get the call? Did they do anything with the call? Like kind of what happens? So here's just a really high level, right? So there is always an initial review. So this is done by usually a single person in the county, a hotline supervisor or somebody along those lines who's really well versed in Volume 7 and knows we need to go now, right? This isn't something we can wait for. This is, and we get these calls every day, right? Small percentage, but we get these calls every day. These are, car accident happened, mom and dad were in the car and they're no longer with us. We got to find placement for kiddo. Like we can't afford to go through other processes. We're going to send somebody immediately. I will say rarely are substance exposed newborns an immediate response for child welfare. And I will say that because they are in a pretty safe place. Like when we are looking at safety for that child, we can be pretty well assured that that child in the hospital with all of those medical professionals is safe, right? Now, the worry about is discharge in those pieces, but usually the initial review says, yep, the kid's safe. We slide to the next one, red team. So for the past, I think we implemented this 10 years ago, maybe 9. All counties, when they receive a referral, go through a red team process. Red is a review, evaluate, direct. It stands for something. It's a framework process, right? It's a group decision-making process in the county to see if the information we have at referral meets our legal jurisdiction to go out. So child welfare does not have the ability to go out because I'm worried, go out and check on a family, go do a welfare check, just go see how things are. We cannot do that legally. Right? Law enforcement can, child welfare cannot. So we have to make sure before we knock on someone's door, before we hop in the car and go to the hospital or see families, that we are supported legally in being out there to make that intervention, right? So, and I always say this is anchored in the Constitution, right? You are allowed to raise your kiddo how you see fit. And child welfare is a small pause on that right. Because we're going to come and say, is how you see fit safe? Right. So we kind of pause that piece. So we have to take that pretty seriously. So a group of folks, the decision and go through those things. We either screen in that referral and then make an assessment and somebody will come out and see the family, or we screen it out. I will say the important piece here, in general, not substance exposed newborns, in general, we screen out child welfare screen about 70%. It's like 65 or 70% of all calls to us. They do not meet legal jurisdiction. We cannot go out. Substance exposed newborns, almost the exact opposite. We screen in about 70% of those, right? And there's a number of reasons for that. One is these are highly vulnerable human beings, these infants, right? The situation going on is highly serious. And we also trust our mandated reporters. Most of our substance exposed newborn referrals come from hospitals, right? You've seen how many families, right? So if you're concerned, I'm probably concerned. So we definitely put our trust in you and knowing what you see. So if you're worried, we tend to screen that in. Next slide, please. So this is the framework. It's all counties use it. All counties have to use it. It really is. If you look at one side of the thing, the danger, harm, complicating factors. The other side of the thing is ongoing safety and strengths. So think of it like a teeter-totter, right? And then the next steps is in the middle. Like what are we going to do, right? This is where a plan of safe care can add a whole lot of things that at the time of birth we either don't know, haven't had the conversation about. The right person isn't in the room, all of these things, right? It's a pretty bad time to talk to somebody, right? Like wake him up and say, hey, I need to talk about this. Yeah, great question. Very interesting county to county. I will say on the process, no. And I put that in like a small no, not a capital no, because many of our small counties are really small. Like they're 3 staff members, right? Like, our big counties are 300 staff. So when I say a group of people for a small county, it might be a supervisor and a caseworker. That's the group, right? It might be a director and a caseworker. If for El Paso County or Denver County, it's 6 or 7 people in the room, all doing just intake child welfare, right? So the process is the same, the documentation is the same, the intent is the same. But no, if we get in the detail piece, it definitely will look different in our smaller and mid-sized counties for sure. Good question. The data stays relatively the same though, for El Paso, big counties, Denver, Douglas, all the way through our very small counties, Delta, Montrose, Yuma, right, Jackson, Grand, our teeny tiny ones. Still tends to be about 30% screen out, 70% screen in for substance exposed newborns. But this is what we do. Next slide, please. So really when making the assignment, we have to make sure it meets our legal jurisdiction. The biggest piece here is we have to have a victim under the age of 18. So this is where we do get a good number of reports about moms who are pregnant, right? And a lot of concerning information, and we absolutely appreciate the phone call. We cannot go out in Colorado, just how our laws are written, on a pregnant person unless there's another kid in the home and the behavior is affecting the other child, right? So a lot of times what we will get is a report for, mom's using or whatever it is, and she's pregnant, okay, and she has another kid. And sometimes it's really hard to make that connection. Well, does this use affect the parenting of the other kid? Do we not know that? So there's that, right? Like, is the other kid 17? It may be different if that kid is 1, right? And that parent being able to meet that other kid's needs. So I just say that because I know we're talking plan of safe care and we're talking really good practice for families and how do we support them throughout, and our limitations legally on being able to intervene, even no matter what the report says, before the baby is born. Next slide, please. Cool. So if we do screen it in, if it's part of that 70% of substance exposed newborn referrals that we do screen in for an assessment. Uh, Likely, we will screen that in as low risk, meaning the child's in the hospital, the child's safe. We have 5 then days legally, calendar days, to go out and see that family and child, right? Make efforts to go see that family and child. And I know some of you are thinking, oh my gosh, like they're going to discharge in 3 days, right? They might. They 100% might. There's nothing saying that we need to see them in the hospital. If we're really concerned, or if there's some other information that you might not know, or that that we know on past behavior or past removals or past law enforcement history or something, we might come out to the hospital. Quite frankly, that's easier for us, and it's not necessarily best practice. And here's why I say that. My life looks very different inside my home than it does when I'm at work, right? How I speak, how I present, how I act, it just looks different, right? Also, my kid looks different. I was just at my kid's school this morning. By the way, he's amazing at school, incredible. He listens, he's polite, he behaves. He comes home, slightly different, right? Like, and he's more comfortable, right? So the behavior is different. That's what I want to see as a child welfare caseworker. How is that home life? How is that parenting? I can ask you how you parent, and you can probably give me very good answers in the hospital bed with your partner there when I don't have to see you parent, right? But then watching the other kid jump off the couch as we're trying to have a conversation, I mean, that's the real deal. Like, how are you going to parent now, right? And so we get to see that. So we tend to prefer to see the family in their home. So for hospital staff, you don't know that. You might not know that. You might not know that we went out. You might not know that we accepted this and are getting involved with the family, because you just know that we didn't come to the hospital, right? The other piece that did we go backwards a slide? I think we did. There we go. Thank you. The other thing we did is I put poor Elena to sleep, and she leaned on the keyboard. Another piece that we do is we have to do safety assessments. So I haven't even said the word removal yet. Like I'm just talking about, like, do we even knock on a door, right? The idea, and I totally understand this, family perception and, quite frankly, public perception of what child welfare does is like, what, 50% removals or something, right? That's what folks know that we do. I mean, it really is. And the numbers are like 4% of all phone calls to us, we end up removing those kiddos. Right now, when it comes to substance exposed newborns, right, it's a little bit different. I told you we screen at 80%. Numbers are different, right? It's like 6. So it's 50% more, which is a lot, by the way, right? But that's still 6 out of 100 calls on that we end up removing those kiddos. It takes the threshold for us to remove is we have to say that this child is not safe here and cannot be made safe here. So those two, we don't always get to that second one, right? Like, many times it is, yeah, you're right. This person cannot care for this child, but this other person can. So let's bring that person in, right? Many times that is the solution. Or this person, I don't know how they parent, so I want to bring somebody in for a short term just to see. That prevents me from having to remove the kiddos. These are the criteria for marking a no. A situation has to meet all 5 of these for us to mark a yes, that the child is not safe. And I know I kind of go backwards, but for us to mark that a child is not safe, something has to meet all of these criteria. That's a lot. It's a high standard for us to say child is unsafe. And therefore, we go in front of a judge to ask to remove the kiddos. Next slide, please. Questions, comments, concerns, complaints before I go forward? Anybody want to verbalize?
You have 2 questions in the chat. One says, for infants that are exposed in utero who are medically vulnerable, but not to the extent where they need to be hospitalized, does that 2 to 3 day window of infant being at home pose risk that is relevant? Is that a situation that happens very often?
I forget sometimes that I have medical folks on the call. You make it hard for me. Let me just read it one more time. I want to say everything is relevant, so I never want to say something is irrelevant, right? Like, it's not relevant. This is one of those things where we would be asking a lot of questions at our hotline call, right? Like, when it starts to come to diagnosis, vulnerability for what, right? What could happen if needs are not met at home? We're going to have to engage in a conversation, right? Because I'll tell you what, right? I have an MSW and an LCSW. That's not an MD. That's not a whole lot of other letters that you all have. I don't know. So you tell a lot of this is going to be, um, they're going to be going home or they're going to be here. If they don't get this kiddo could what, right? Could lose a half a pound. I mean, that's not great for an infant, right? Like that's a lot of weight. Or this could not live. Like, oh boy, like that's a very different conversation. So I guess we definitely would be engaging in a lot of conversations. And everything that by the way, is relevant. Now, I don't need the full medical chart, right? Because I'm not going to read it. I'm not a professional enough to read what that means. But I do trust your succinctness on giving me that information for sure. And what's the other question?
It says, if a patient has either disclosed substance use or is considering disclosing it and is scared about what will happen to their child next, what should/can hospital providers advise them?
Kaylin, I can tell you what I would say, but you go first.
Yeah, I'm actually curious if I'm saying is what you would say. So, how I talk with folks about this before, and almost everybody that I end up talking to has disclosed substance use at some point, right? Whether it was their like intake prenatal visit with our nurses, whether they spoke to another clinician who they disclosed substance use, whether they specifically came in and said like, hey, I want Suboxone, like, please direct me. So it might be a little different if somebody's considering disclosing, because I'm usually seeing folks post disclosure. But what I say to folks is, and we can talk about this in multiple ways, but the desire to hide and conceal what is likely to still affect your or your kiddo's health is really normal, right? It's like, it's not a bad thing. It's a normal human response to want to like keep this secret and not talk about it because it's scary and it's people don't really know. I would say, Matt, honestly, in the substance use community, I think the impression is like 100% removal, right? Like there's really, it's almost this very like dichotomous thinking of like, if I have substance use in pregnancy, 100% removal. But so that's what we talk about, is that whole in between of like many people who have substance use histories, many people who are engaged in substance treatment go home from the hospital with their babies. And here are the things that we can do ahead of time to maximize you being able to take your baby home with you. And that looks like hopefully seeing readiness for treatment, right? Are we ready to engage in some kind of treatment? Is the goal sobriety? Are you open to inpatient? Are you open to outpatient? Kind of talking through the spectrum of treatment options. It can look like starting to pull in our resources. So this is, if somebody's saying like, no, I really don't want to be in treatment. I'm not open to, inpatient. I don't want medication. That's when I would start thinking about like, okay, what else can we put into the home environment? Is it housing? Is that what we need? Like, do we need housing? Do we need a sometimes supportive family member who can come and move in with you? Right? Sometimes folks are like, oh my gosh, like asking somebody to move in and help this person and 24/7 supervision is a big ask. And it is a big ask, but it's not so different than what we should do for all of our pregnant people, which is helping them mobilize resources ahead of time. To think like, you're going to go home from the hospital with this brand new baby, who can help you? I think that's a reasonable question for every person potentially. But just asking people to start thinking about what kind of resources can we mobilize ahead of time. And then being transparent about this is how this goes down in the hospital. And again, trying to pace and feel out how much that person can absorb at any one given time is my goal.
Yeah, and I would say, I think it's the conversation of what does that use look like for you, right? Notice I haven't talked about any specific substances or alcohol or anything else, right? But when you use, what does it look like, right? What does your behavior look like? What is your ability to care for it if you have existing kids? What does that look like? How do you plan around those? So what can we do around support? And whether that's planned use, whether that's bringing in somebody, whether that's financial, whether that's whatever the thing is, so that the kiddo, once born, is never unsafe, right? So how do we plan for having the conversation that if child welfare does get a phone call, and if child welfare does respond, and if child welfare does come out and talk to you, that you're prepared for the conversation, right? My kiddo had an incident happen yesterday on the bus, and he had to talk to his principal today, and he was petrified, and he wasn't in trouble, and he had no worries, but he was petrified of talking to this principal, right? Like to the point like he almost got sick. I'm like, dude, you need to settle down. But that's this conversation, right? That's this thing right here is where, like, geez, if child welfare comes to talk to me, what are they going to say? And how do I answer? And how much should I tell them? How much should I lie about? Because I don't want them to take my kids, but I don't want to lie, but maybe I need to. And if we can have that prep and have that support and say, yes, I do use whatever, and this is how often, this is what it does for me, this is what it doesn't do for me. I understand, when I'm incapacitated, I can't take care of my kiddos. Here's my plan, all right? And I've already done this. This isn't even a plan for like, I hope this works out, right? But if I have a kiddo, I do this now, right? And I wish I could get off the substances. Maybe I want help, maybe I don't, maybe I'm not ready, somewhere on that theory of change wheel, but my kiddo's never going to be unsafe because, right? And I may or may not agree with you. That's a different piece, but you're prepared for that conversation in that language. So we start off at level ground, right? I know what I'm going to ask as child welfare, and you know what I'm going to ask. So we're okay. We've thought about it beforehand. That's what I say. If anybody can do anything to help prepare for what that may look like, that's helpful. The other piece I think to me is what I was referring to earlier. If we get 100 phone calls, we only, for substance use disorder, substance exposed newborn, we only screen in 70. And out of that 70, about a third of those do we open cases on. And out of those, only 6% do we remove. Like, it's not one-to-one, right? So even if child welfare does show up, there's a really good chance we're going to leave within 60 days. We've gone out, we've assessed your family, we've assessed the safety in the house, we've determined the kiddo is safe, and we're going to leave. So that's the vast majority of our interactions. And again, you might be the exception. We can never make guarantees. We don't do it, you can't do it, right? That type of thing. So hopefully I answered the question. And then, Carly, I see the follow-up. I always love if it's the clinic, whoever's doing the discharge and has the information is making the referral. I understand sometimes that is not in the cards, and I'm talking to social work who maybe didn't have the same conversation as doc did or the nurse did, or sometimes there's some of those pieces. But whoever can give me the most information on, I'm relying on you a little bit to tell me how worrisome some of these things are, right? And I don't want fear factor, right? I don't want like the 1%, this happens. Like, I mean, that's real, right? But 80% to this is what happened. Cool. Then I'll kind of work with those numbers. And that'll be on us to kind of figure it out.
Hey, Matt, there was an earlier question specifically about THC reportability.
Okay.
And I think this might be the time to address, because what you said before was like, you haven't talked about any specific substance, right? It's not like these substances positive in the umbilical cord, automatic call, and these substances like up to your discretion, right? It sounds like what you're saying is, no matter what the toxicology, it is still up to the context, right, of the family. And so I'm curious if you want to answer that question that Barb had earlier about THC specifically.
Yeah, I see it, Barb. Sorry, I got lost in the scrolling chat in there. So we don't differentiate in child welfare on specific substance type, right? And if you go back all the way to the first slide in the criteria, we list alcohol and then substances, right? Like, so everything falls into two categories, which by the way is ridiculous, but it all falls in there. We don't break them up because it's the impact that we are really looking for, right? Mm-hmm. Is the use affecting the child and parent? And what's that impact to the child, right? And because we get almost no calls on alcohol, by the way. Very, very few, right? So you can't tell me that nobody's drinking pregnant and didn't tell anybody, right? Like, so that tells me that we're already self-selecting kind of, which calls make it through and which ones don't, right? I'm never, by the way, going to tell somebody not to report. So let me just be really like, that's not a thing I'm going to do. I always do like the food that fell off the table rule, the 3-second rule. If you're going to worry about this for 3 seconds after that patient leaves, like you're like, oh, geez, I don't know if I made the right decision. Should I, maybe not. Just call, I guess, is my always like, let us take the worry is the one thing. And we were really intentful in changing statute and rule so that it isn't just mom test positive, therefore I have to call, therefore I have to go to open a case. Like, we really want to slow it down and lean into your expertise too, right? So I don't even say like THC, I can't even put that in the same levels because we have folks doing shatter and dab, and that is very different, and impact on that is very different than having a joint or having an eighth of a cookie or something. Like, how that affects mom. And that's why I like those conversations on when you use what happens. You know, do you black out for the day? Now I'm really worried, right? Or no, then I go to work. Like, oh, like, okay, how did you do that, right? So I think there's a lot of stuff in between there. I hope I answered your question, Corbin. If not,
Yeah,
dang it.
can I, so I think a couple things, and I know we're short on time, but one is we don't test for alcohol in the way that we test for THC. So I think there's already something, and that's more, I think, in our systems that we need to think about. And then the other piece is, I think, speaking to what Kaylin said earlier, I have this mom who's been reporting marijuana use throughout her pregnancy. To have a child welfare report, which cannot be made until that child is born,
Right.
seems kind of dumb to me, because it feels like this is the thing, what like Kaylin was saying, and maybe I just need more info on this because I'm new in this particular field, is how do we help that not be a thing that happens postnatally when there's a whole lot of hormones and other stuff going on? How can we prepare that ahead of time with DHS? Like, we're pretty sure this person's going to be positive. She's saying she just smoked yesterday. Even if the court isn't positive, we just want to call and let you know. So it's not like a, oh my God, emergency in.
Yeah. So and I guess so. I don't want to say you can't report, can't do anything with it. Like, it automatically will get screened out because we do not have a victim under the age of 18. So you can make the reports. And I know some hospitals used to make reports, and we used to try and keep them, and because we were worried about people running away or something. Like, we were a pretty punitive system, and we would try and do that, but we can't do any. So just like that's one thing. Two, what does that actual use? How does that impact the safety of that kiddo? That's right. So mom is reporting use, and mom is saying, I'm going to continue to use, by the way, right? Like, thanks for your help and thanks for the offer, but I feel like the kiddo's safe. Like, I feel like I can care for my baby because, well, tell me why, right? Like, tell me what that looks like for you and how you're going to meet that baby's needs. Also, what is affected if that baby's born and there's severe withdrawal symptoms? That's very different from they're eating, they're sleeping, they're being consoled, and we're not going to change our medical care based on a plus or minus on a test, right? If we're not going to change that, don't do the test for me, right? If it's going to change in medical care for the kid, then do the test. Do all the things that you always do, right? Do those things. But all I'm saying is I don't need a test. Also, I'm going to take it one step further, Barb. There's a piece in here that, depending on mom's behavior, I might not screen this in for substance exposed newborn. I might screen it in for something else, right? If you're saying mom's behavior is erratic, mom is unable to focus and take and recognize cues from the baby when the baby's crying, and she's unable to feed the baby, and she doesn't hold the baby. If I don't even need to know the why, but you're telling me those behaviors, and you feel like that's worrisome, right? We can screen that in for a neglect, injurious environment. We can get involved for other things besides substance use exposed newborn. So that's okay too. Like, I just want to say that also, right? And we don't feel like we have to shove everything into this box, right? We have those other things that we can get involved for. So I guess those are the two I don't know if that answers your question though.
And that's part of the prenatal plan of safe care conversation too, is not just like, can we get to the end of your pregnancy and have a negative test, right? It's thinking about what else is there? Because I've definitely had families that are seeing me for treatment for substance use and doing fairly well, but I'm calling about intimate partner violence in the home, or I'm calling about, somebody else or some, other concern, right? I think that that's fair, that there are multiple concerns could be present, and that substance use could be part of that, but maybe not the only concern or the main concern.
Yep.
And so I think what I heard Matt say is, I just want to go on record, Matt, is that if somebody is reporting cannabis use, we know that they will likely have a positive toxicology at time of birth, but we do not perceive any way in which their cannabis use has impacted their ability to engage in prenatal care, take care of their baby in the hospital, or describe how to keep their baby safe at home from secondhand smoke and from cannabis poisonings, that there could potentially be a scenario where you do not have to make a phone call.
Yeah, that's 100% correct. That was why we changed this. It used to be positive test. You had to call it. We had to get involved. End of conversation, right? And we changed it really intentfully to say, like, are you worried? Because we used to get so many phone calls from hospitals that said, hey, by the way, I'm not worried, but, right? Like, we still get some of those, right? Like, I'm leaving a mom's room right now. She just admitted use of whatever, while pregnant, or we're going to do a drug test. It's still pending. But I'm not worried because mom's here, dad's here, grandparents are here. They have a plan to go home. She's recognizing all the cues. Like, mom's amazing. I'm not worried. But she said this thing, and I think I have to report, right? Don't feel like you have to report when you aren't actually worried about child abuse and neglect. Like, I mean, I think that's, if you're worried about potential of child abuse and neglect, please call. And if you don't know, we'll help figure that out. But there are absolutely things that were reported prior that no longer need to be reported. That's correct.
I don't know how many slides you have left, and I'm sure there's going to keep coming up questions. We do need a little time at the end, but I think that what I'll do is I'll share your emails at the end, if that's okay with you both. And if there's more questions, they can direct it to both of you.
Can I ask for one of, we have several social workers who have joined us from various hospitals, and I'd love it if we could just have like a minute or two for anybody who's actually doing this day to day to share kind of their perspective and their thoughts about what we just talked about, kind of how this goes down in the hospital for you as the person most likely to be deciding whether to make a phone call. And so I think, Elena, can you go to the next slide? I think there was one more. Oh, go ahead.
That one right there.
Keep going to like the last slide. Yeah.
Sure.
Sorry, one back.
There you go.
Yeah, those were kind of my questions for anybody here today who's in this position frequently, or has been in this position of being asked to assess a family in the hospital and then decide about making a phone call to CPS. I would totally welcome your thoughts.
Hi, Kaylin, this is Kelsey and Heather at Denver Health. And we also have our counterpart, Hannah, who primarily covers mom baby. And this is pretty much our daily work. So I'm gonna let Heather speak a little bit more. I do Pete's Picky primarily, but Heather and Hannah are the ones that do the NICU and mom baby. And like I said, get these types of consults daily at this point.
Yeah, first, I just wanted to say, Dr. Klie, I was not aware that any conversations were really starting with the plans of safe care prenatally. And so I just wanted to clarify with you in regards to that taking place. Is that something that just you are doing? Do you know if that's an expectation that's being rolled out to our OB clinics for our providers and social workers to be involved in? Is there a template for that, or what does that look like?
Not yet. I mean, I think that would be kind of next step. I've made my own template from stealing part of the inpatient peds template, right? Because I'm like, oh, here's the list. Here's the checklist of things that you're going to look for when my patient had her baby. These are the pieces we can probably do prenatally, right? And pull that into the prenatal space. But even for myself, that's been more of a recent, like I'd say only within the last couple of years have I been aware of kind of how to pull this into the prenatal space. So I would not say that it's probably a fair expectation or requirement for every prenatal care provider, but I hope we can move in that direction.
Yeah, that sounds great. That would be amazing. I think we would definitely on the inpatient side of things be on board and appreciate that support from the outpatient staff in general. I think where there's like the most gray, it seems like in general, the child protection reporting is around marijuana. And when court is positive for marijuana, I think, you know, I understand this language of the infant being affected, or the parent being affected, and then what is the impact? I think sometimes with marijuana in particular, it is tough to assess that in just a one-off interaction with a family where you may only be meeting with the one parent, just the mom, and you don't have any kind of collateral from any other family members. And I think that, I've been seeing some questions in the chat about the marijuana reporting, and I think there's just some ambiguity there still. And that's what I feel like the biggest piece for me is we can ask these questions and we can get information. And still, it's like, I feel like there's always a level of skepticism that, we need to, like, to an extent, be skeptical of some of the information that's being provided to us, because we don't know where the truth lies. And so that's what's hard looking at, like, or trying to discern, like, how a child is being affected or a parent is being affected and what the impact is in just a one-time interaction where we might have a baby that's born the night before, they're discharging the next day, we're meeting the mom one time, and it's just like real quick. And just to be able to have the full information to make an informed report can be difficult. And then from there, I hear what you're saying, Matt, when it's like, you don't have to report, but it's like, we only have so much information to go off of in the limited amount of time that we have. So I think that's where it's kind of tough.
I completely understand. And I threw it in chat too for answering somebody else, but you only know what you know, right? Like I would never ask hospital staff to do what we do and ask the questions that we do and that type of stuff. You know what you know. So if you only have a limited piece of information, are you worried or not? And again, if the answer is no, or I don't know if I should be worried, right? Like, should I be worried? Question mark, right? Then does that mean you are or you aren't, right? And I don't know how to, based on your experience working with moms and babies, right? Like, I'm going to lean into that, right? So when you're calling and saying, yeah, I am worried, or I'm not worried, but I think I should be worried, I'll take all of that into consideration. Because, again, I want to make sure that you're the ones seeing the moms, you're the ones seeing the babies, even if it's for a short time, it's still more than we have, right? And you're the ones who have seen that and know what a healthy mother-child interaction looks like in a short period of time and those types of things. So if you're worried, yeah, we'll take the phone call. So I also want to get away from, like, we're no longer going to be able to provide a if this, then this every time type of, yes, no answer to these things, because that didn't work. We know our minority over-reporting is ridiculous across the states. Like, that's a fact, right? So the moms that we test, the moms that we ask questions to, the moms that get called, we know we're not close to where we need to be. So there's something else happening there too, right? So I guess just all of those considerations, there's a lot to take in. So
I think, so I've been here 5 years, and like the protocol that we've always been told, it would be up to me to look up a policy, is that if there was a positive cord result for marijuana, so Utah specifically, because we don't get the cords right away, we are to report it. And so that's why it sounds like, though, there has been some laws that have changed that we're protected by, that we don't necessarily have to report that if there are no other concerns. Is that correct?
That I'm not going to tell you what your hospital policy is. Let me be really clear.
I will follow the policy. But the law states that we no longer have to report. Okay, that's great, because this has been like an ongoing challenge for us, because most of our THC referrals are because of positive, and we typically do not have other concerns like based off assessment and history and the chart and all of that. So that's great clarification moving forward, and then we can look into our hospital policy.
I think that's a separation too. Like, the state requires this, and other hospitals or risk management are not. I know everybody's going to call their risk management attorney is like right now and go for it, and see what policies can change and which ones can't. I'm not going to tell you what you need to and what you don't need to do. I'm just saying we have built in now into law critical thinking, right? And trust in our professionals in some pieces. And it's new and it's different and it might be uncomfortable. I totally agree. So if we need to have further conversations at a high level or on a county level, happy to arrange those and have those conversations.
No, I think that's great. We've been wanting this for a long time. So,
and I think just separating out too, right? The important thing of what you're saying is, like, there may be a scenario in which we really want this person to have some follow-up, but we don't need CPS to be the follow-up, right? We may say like, wow, we really want you to get this support service in place. We want you to have this prenatal visit or postpartum visit scheduled before you leave. We want you to have a referral to mental health support. So I think just kind of keep it for everybody, like keeping separate in our mind that like not reporting to CPS does not mean that we can't provide robust treatment recommendations. And then decide, you know, if that can't or doesn't work out, revisit, you know, communicating to the outpatient people and picking up the ball and running with it, that, you know, if this family is really struggling, the only opportunity for reporting is not birth hospitalization. It could be, you know, they're missing well child checks, nobody can get a hold of them, and then we are more worried.
And then to add, I agree with everything Kelsey and Heather has said. And I think we, in my experience on the mom baby delivery unit, have erred on the side of rather being safe than sorry. Because we don't know the history. I used to be a child protection services caseworker, and a family can present very well in the hospital room and say whatever they want to say. And we don't know if there are other concerns or whatnot. And because sometimes it's a matter of like protecting our own license, we err on the side of we should make the report because we don't know the background. We don't know what's in trails or what's in the court's history. With that being said, it has kind of been a thing on the mom baby on here, I feel like on the mom baby unit, where if they stopped when they found out they were pregnant, typically we won't make a report. However, or if they stopped within the first trimester, because a cord won't show results that far back to get a positive as well. But if we were to get a positive urine or a cord, then we've been just always making the reports to protect ourselves in a sense. But yeah, it's really hard because it is such a time-consuming thing to always be making reports for marijuana when, you know, on our initial assessment, we don't have any concerns. But like Heather said, it's such a small meeting. It's hard to know kind of, you know, what to do at times. So I think we've always just erred on the side of caution with those types of cases.
Well, so I live in a small town and things are really different. I recognize that. And you guys are dealing with huge volume. But like somebody in the OB clinic might know, right? Like about that. And it feels like we're missing some communication. Like in where I work, I can have that communication easier because I overlap with the birthing center and the OB clinic. But so that's just my thought. As I'm listening to people, like, that's one way to find out if people think that this person's been like keeping their appointments and doing what they need to do. And I don't know how hard it is for you guys to make that connection, but I feel like, I don't know. For me, I keep looking at this the way we don't test cords for alcohol. We don't do urine like screens for alcohol. There is some profiling going on. Someone said something in the chat. It feels like sometimes, so like that piece makes me really uncomfortable. I just feel like I'm glad for this change. I know we need to protect babies, but we also don't want to ostracize these moms from getting the treatment that they need and getting connected with aftercare services, and DHS can do that too, right? Like that. And I don't know if you guys have the time, like, are we making calls with moms to the county? Like, because that's also super empowering because then they're just saying it themselves. I don't know. Those are my thoughts, but I'm new. So I'm asking all the dumb questions at the moment in the OBGYN clinic.
Those are not dumb questions, but we're at time and I really hate stopping this really rich conversation. I will be sharing the slide deck and this recording following this, as well as the contact information for Matt and Dr. Klie. If you would like continuing education for this webinar, I have the QR code and the link on the screen. We'll be sending that out. And then if you could please take the 5-question coaching call evaluation, we would love that. But I just want to thank Matt and Dr. Klie so much for this really amazing presentation. I think that we've had these conversations at the past meetings and we've all been like, wow, we don't know what to do. And so this is really helpful hearing from you. And I would love to continue this conversation in the future. So thank you everyone for coming, and thank you both so much for presenting today.
Thank you. We need just like a separate social worker meeting.
Yes.
Hang on. Sorry. Hannah, do you know my niece? Did you see my thing in the chat? Do you know Anna Corcoran?
I did, but to be honest, I work with so many
You
nurses.
don't.
Like it's not very often I remember, unless I see them literally on
I
a
know.
day-to-day basis and they're